in Adobe, and I'll be presenting practice question 7. The question: classify disease based on duration. Give 2 examples of acute diseases in cardiology, endocrinology, and neurology. What is the term used for selection of patients that present to the emergency using their clinical presentation? List color codes used in medical emergency. What does the red, yellow, green, and black codes mean? A 19-year-old type 1 DM patient presents with fever and abdominal pain. What color code will you assign him? List factors on clinical exam that will determine your choice. Few hours later, his GCS dropped to 4, and he's found to have bronchial breath sounds, and elevated random blood glucose of 20 millimole per liter, and ketonuria. What code will you assign him now? And what is your diagnosis? Outline your management plan. Please try to briefly state what you would do in each step. That's the type of IV fluid or insulin to use. So the answer to the first one, classify diseases based on duration. Okay, we have acute disease, subacute, and chronic. Acute disease develops suddenly and could last for less than 4 weeks. Subacute disease is in between acute and chronic, about 4 to 8 weeks, while chronic disease lasts for more than 8 weeks, and it may get worse over time. Examples of acute diseases in cardiology, endocrinology, and neurology: acute heart failure, acute myocardial infarction, acute pericarditis, DKA, HHS, hypoglycemia, acute adrenal insufficiency. Under neurology, status epilepticus, intracerebral hemorrhage, subarachnoid hemorrhage, acute meningitis, or encephalitis. What is the term used for selection of patients that present to the emergency using their clinical presentation? It's called triaging, and it can be simple or advanced. So simple triage is used at the scene of an accident or mass casualty incident. Patients are usually sorted into those that need attention and immediate medical care and transport to the hospital, then those with less injuries. Under the advanced one, this one is specially trained doctors, nurses, and paramedics that do this, and they identify seriously injured people, and they now decide those that don't need treatment based on likelihood of survival. So if the patient may not survive, why spend resources on them when you can use it to resuscitate others that may survive? So it's used to conserve these scarce resources. So the color codes used in medical emergencies include red, yellow, green, black, and white. What does this code represent? So this table shows what each of them represents. Sorry, it's tiny. Red is those that need immediate attention for critical life-threatening injury or illnesses. These ones, they need to be transported first. Red tags are usually labeled on them, and it's labeled on those who cannot survive without this immediate treatment, but they have a chance of survival. Yellow, those who have serious injury needing immediate attention. They require observation, but their condition is currently stable and they're not in immediate threat of danger. So though they still need hospital care, and they'll be treated immediately under normal circumstances. In some systems, these yellow tag patients, they are transported first because they have a better chance of recovery than the red. Then the green, these ones can wait. Their injuries are less serious and minor. It's not life-threatening. You can delay transport and attend to those in red and yellow first. Then black, expectant, these are deceased or mortally wounded. Black may not mean that the patient is already dead. It might mean that he or she is beyond help, therefore lower priority. So we would attend to others before this black. Then white, these are those that don't really have injuries. So after
Hello, sorry, good morning.
Good morning, sir.
Good morning. Can you hear me? This is Dr. Cookie. Your screen has never shown at all, and everybody kept quiet. I thought it was only me. It was when you said, oh, sorry, this thing is tiny, and I said, oh. So you were actually presenting with slides. I thought you were presenting without slides. I came late, and I thought maybe you had apologized to the class and you were presenting without slides. From the beginning, nobody saw your slides at all.
Chukwuki, we are
Good
seeing
morning,
it.
Ma, we can see this slide, ma.
You can see slide. Oh, you
Sorry,
can
we
see.
can't see it. I
We
can't
can't
see
see
it.
it.
I can't see
Yeah,
it though.
I can see it, but
Sorry,
it's
let me
time.
unshare
I
and share
cannot see
again.
it.
If
So,
not everybody can see it. Maybe it's from my end. Let me unshare and share again. But I was told they could see it, ma. That's why I started presenting.
It's not
I can-
spiritual slight.
Please, that your phone. I think the problem might be your phone, Dr. Obiefuna, right?
Yes,
yes,
sir.
yes, sir.
Please, it's likely a Chinese phone. Sorry, it's likely an advanced phone. Please get a phone that is at our level. How can you be selecting people to view and not to view? That's fine. Huh? This is the first time I'm seeing this one. Eh?
Noted, sir. I don't know what happened, but sorry about that. Okay, I stopped at the table showing the color codes and I'd finished it. I said red needs immediate attention, they are life-threatening conditions and have 50-50 chances of survival. Yellow will survive better. Green, less severe injury. Black, they're almost dead, but there's still hope. White, nothing serious, so they can be dismissed and you concentrate on others that need attention. Next slide, please. Okay, so going to the clinical scenario about the 19-year-old type 1 diabetes mellitus patient that presented with fever, abdominal pain. What color code will you assign him? So assign him yellow because he's has an emergency, but it's not life-threatening. Then the factors to determine this color code on clinical examination include the level of consciousness, pulse rate and blood pressure, bedside random blood glucose level, the serum urea and creatinine, respiratory rates and their pattern, hydration state, the arterial blood gas urinalysis. Next slide. Few hours later, his GCS dropped to 4. He was found to have bronchial breath sounds and elevated random blood glucose of 20 millimole per liter and ketonuria. What code will you assign him and what is your diagnosis now? So this is red because his GCS has dropped. He's actually in coma and it's life-threatening. So we will have to act faster. So he has diabetic ketoacidosis, and this might have likely been precipitated by community-acquired pneumonia. Okay, so diabetic ketoacidosis, the blood glucose is usually more than 60 millimole, greater than or equal to 60 millimole per liter. Ketonemia of greater or equal to 3 millimole per liter, or significant ketonuria of greater or equal to 2 pluses on urinalysis. Metabolic acidosis with venous or arterial pH of less than or equal to 7.30, and or serum bicarbonate level of less than or equal to 15 millimole per liter. Sorry, I have allergies. Changes in DKA management in the past decades. So now they say you can measure the capillary ketones and not urinary, and using capillary ketone level to guide treatment rather than the capillary glucose. Then measuring venous or arterial pH and bicarbonate, since the difference between arterial and venous pH is not so significant enough to influence the diagnosis or management. So why they're saying you can measure the venous pH is sometimes it's harder for people to get arterial blood. So why stress yourself when there's no difference in the management? Use weight-based fixed rates IV insulin instead of sliding scales. Monitoring of electrolytes on blood gas analyzer with intermittent confirmation. Next slide. So interpreting capillary ketone level, this is just to show us the range. So the normal is less than 0.6 millimole per liter. When it's 0.6 to 1.5, you know that there are more ketones being produced. If it's 1.6 to 3.0, it's high level and risk of ketoacidosis. And once it's greater than 3.0, you think of DKA. Outline your management plan and try and briefly state what you will do in each step. That is the type of insulin or IV fluid to use. So principles of DKA management: first of all, fluid replacement, insulin therapy or clearance of ketones, correction of electrolyte imbalance. Then you treat the precipitant or underlying infection. So since it's a medical emergency, in all cases, at least we'll do ABC of resuscitation, we check the airways, breathing, circulation, and consider transfer to high dependency unit or intensive care unit if the patient is very bad. Markers of severity in DKA. So we consider transferring them to this high dependency unit when there's one or the following of these findings: when the blood ketones are greater than 6 millimole per liter, bicarbonate of less than 5 millimole per liter, venous or arterial blood pH less than 7.0, hypokalemia on admission less than 3.5 millimole per liter, GCS less than 12, SpO2 less than 92, assuming the patient has normal respiratory function, not someone with COPD. Systolic BP less than 90 millimeter mercury. Pulse greater than 100 or less than 60 beats per minute. Then the anion gap above 16. Next slide. So fluid replacement: usually patients with DKA lose about 6 to 9 liters. So we aim to replace this within 24 to 36 hours. And we try to give 50% of this in the first 8 to 12 hours of presentation. We usually resuscitate with 0.9% saline. And this is how it's given: 1 liter over 30 minutes, 1 liter over 1 hour, 1 liter over 2 hours, 1 liter for the next 2 to 4 hours. When the blood glucose is less than 15 millimole per liter, or it's actually supposed to be 250 milligram per DL, we switch to 5% dextrosaline 8 hourly. If still dehydrated, we continue the 0.9% saline and add 5% dextrose. 1 liter 12 hourly, and we aim to replace 6 liters in 24 hours. So we replace electrolytes if there is hypokalemia. So if it is less than 3.5, we give IV potassium chloride 40 millimole per liter. If it's 3.5 to 5.5, we give the same, but if it's greater than 5.5 millimole per liter, there won't be any replacement needed. Next slide. Insulin therapy: we use IV insulin, continuous infusion with 50 units of soluble insulin in 50 mils of normal saline, and you start at 0.1 units per kg per hour. Target random blood glucose drop at a rate of 3 millimole per hour. You continue this until the capillary ketones becomes less than 0.6 millimole per liter and venous bicarbonate greater than 15 millimole per liter. Monitor random blood glucose hourly, and when it's less than 14 or less than 250 milligram per DL, you commence IV 5% glucose with IV 0.9% saline. Then reduce the insulin dose to 0.05 units per kg per hour. And you switch to subcutaneous insulin when the patient is able to eat and drink, and eventually to premix insulin regimens when appropriate. Next slide, please. So we monitor this patient frequently, monitor the blood glucose, capillary ketones, venous pH, serum potassium, and urine output hourly, venous blood gas at 0 hour at presentation, 4 hours later, 6 hours, 12 hours, and 18 hours later. The electrolytes at presentation, 6 hours, 12 hours, and 24 hours later. Then you treat the precipitant of the DKA. If it's an infection, you give antibiotics. If it's pneumonia, you give the following antibiotics: amoxicillin, clavulanic acid, plus azithromycin. Then common precipitants of DKA: infection, like pneumonia, cellulitis, UTI, pancreatitis. Infection accounts for 30% of the precipitants. Infarction could be cerebral or myocardial infarction. Infraction, non-adherence to insulin. This is just the code to remember it. Or insulin omission. Ischemia, illicit drugs, cocaine use, iatrogenic, steroids, or dextrose infusion, idiopathic. Then in 25% of cases, you get new diagnosis of type 1 DM presenting as DKA. Then pregnancy. Metabolic treatment targets. So we target a reduction of blood ketone concentration by 0.5 millimole per liter per hour. We increase the venous bicarbonate by 3.0 millimole per liter per hour. We reduce capillary blood glucose by 3.0 millimole per liter per hour and maintain potassium between 4 and 5.5 millimole per liter. This is when you know the patient is getting better. So treat or prevent complications like you do DVT prophylaxis, you correct hypokalemia, hypoglycemia, hyperchloremia, and acidosis. Then how you know the DKA is resolving, the pH will now be greater than 7.3, bicarbonate to be more than 15 millimole per liter, serum ketones less than 0.6 millimole per liter. So before the patient goes, you give patient education, you review their usual glycemic control, you encourage them on the need for medication adherence, you tell them about the persistence of DKA and how to prevent the recurrence, review their injection technique, blood glucose monitoring, if they have the equipment, you assessment of education on home ketone testing, blood or urinary, contact telephone numbers for diabetic specialist team if the team is willing to receive calls, and you refer to outpatient clinic for further review. So there are new findings now. So new hyperglycemic emergency guidance updates, DKA definition. This was done October 23. I saw this on Medscape. So they said an upcoming joint society statement on hyperglycemic emergencies in adults with diabetes will de-emphasize glucose from the diagnostic criteria for DKA. And this new consensus report will be jointly endorsed by the American Diabetic Association, the European Association for Study of Diabetes, the American Association of Clinical Endocrinology, the Diabetics Technology Society, and the Joint British Diabetes Society for Inpatient Care. So before it was just the ADA that brought the guidelines, but now all these societies have come together. And the reason they're trying to de-emphasize glucose from the diagnostic criteria is the fact that people are now using the SGLT2 inhibitors, which okay, they said it's because of increasing occurrence of euglycemic ketoacidosis arising from the use of sodium glucose cotransporter 2 inhibitors. So the hyperglycemia cutoff now in DKA definition has been lowered to 200 milligram per DL, which is 11.1 millimole per liter, from the previous value of 250 milligram per DL. However, the glucose cutoff has been removed for people that have history of diabetes. Approximately 10% of DKA occurs with euglycemia or near normal glycemia. So if someone is on SGLT2 inhibitor, there is no need to look at the blood glucose level at all because it may be normal or near normal in DKA patients. The new statement will classify DKA into mild, moderate, and severe and recommend care for each level. Metabolic acidosis is now defined as pH of less than 7.3 and no more 7.0, and or bicarbonate concentration of less than 18 millimole per liter and not less than 15, up from 15 in the previous guidelines, including the UK's guideline. Also, anion gap has been removed from the main definition, but can still be used in settings where ketone testing is unavailable. So under fluid replacement, when using normal saline, they said now dextrose should be added to the IV fluid as a substrate when the glucose drops below 250 milligram per DL, while for euglycemic DKA, dextrose and normal saline will be used simultaneously as recommended. Subcutaneous rather than IV insulin is considered acceptable for those with mild DKA, but in moderate and severe DKA, we continue with IV insulin. The new criteria for resolution of DKA will now be when the pH is greater or equal to 7.3, bicarbonate of greater than 18 instead of 15, serum ketones of less than 0.6 millimole per liter, glucose of less than 200 milligram per DL. So I just added HHS, even though I'm not presenting it. So they say for HHS, the glucose cutoff will now of greater than 600 milligram per DL will still stay. But now the effective serum osmolality has been lowered from greater than 320 to 300 milliosmoles per liter to account for the effect of dehydration, along with an alternative criteria of total serum osmolality greater than 320 millimoles per liter. The same changes in DKA, the two changes for both the ketone and acidosis have also been included for HHS. The new criteria for resolution of DKA is when serum osmolarity becomes less than 300 millimoles per milliosmoles per kg, blood glucose less than 250 milligram per DL, urine output of greater than 0.5 mils per kg per hour, cognitive status improves. Okay, thank you. These are my references.
Well done, Dr. Ada. This is a very good one. Thank you very much. It's actually a nice one. We entertained some comments regarding your presentation. Go ahead, sir. Dr. Kari.
Good morning.
We can't hear you, sir.
Hello?
Yes, we can hear you now.
Okay. Something just caught to my attention from your presentation, and I quickly want us to verify it if possible. When you were classifying acute, subacute, and chronic, and what I was just whether it's generally accepted specific group of. Let me quickly. Acute is for 4 weeks, subacute and and I was just because for different special.
Chief Academy, I can't hear you. I don't know if I'm the only one.
His line is breaking. We can't hear you, sir. Okay, we can hear you now, sir. Go ahead, sir.
Are you using earpiece? Can you remove the earpiece, Chief Academy?
Let me see whether my. Okay, maybe I would. Hello?
We can hear you now, sir.
It's okay. Sorry for taking our time. I said I had. Can you hear? If you can't hear, then
it's breaking.
I don't know.
We can't hear, Dr. Coyote. Type it and
please let other.
Okay.
Dr.
Ede.
It in the chat box. Type it in the chat box, Dr. Coyote.
While Dr. Ede can make her comment.
Good morning, my chiefs. Many thanks to the presenter for such an excellent presentation. I just need a little clarification on the potassium correction, because she just mentioned the amount of potassium you give based on the level of potassium. So, but what I had always known, or rather what we practice in our center, is you calculate the deficit and then add it to the person's total requirement based on the kg body weight, and then that's how you administer. Either you give it over 3 hours, or 4 hourly or 6 hourly, depending on the level of dehydration. So I just wanted to confirm if it's less than 3.5, you give 40 millimoles. How is it a new guideline? And then if it is, how is it given? Is it giving start over how many hours? Thank you.
All right, thank you. Chief Ada, can you respond? Hello. Dr. Ada, can you respond to her question, please?
Yes, Chief. She's correct. I didn't put the formula, but you calculate the deficit. Though I don't know, I was using different resources. Under this National Institute of Health, they just put 40 millimole in each 1 liter. They didn't put calculation, but ideally what we practice here, we calculate the deficit and replace it. So
hello, Dr. Ada. Hello.
Yes,
hello.
Chief.
Yeah, so in a normal person, That's what you do in someone that does not have a hyperglycemic emergency. For example, while calculating the deficit, you use 4. So what it means that anybody that has potassium of more than 4 or up to 4 will not require any correction. There won't be any deficits if you use that. But if you look at your formula, even someone that has 5 can still get correction. Okay. The only thing is that in that, like that second one is actually 20 millimoles, not 40. Okay. I think I'm seeing 40. It's 20. Is when it's less than 3.5, you give 40. So, but in a normal person who has hypokalemia or someone else, somebody that does not have that does not require insulin therapy, because basically here you're going to give insulin because of the hyperglycemic state. And remember that insulin drives potassium into the cells. So even when the potassium is apparently normal, because of your insulin treatment, the potassium is going to be reduced further. So you want to correct, okay, even when it's normal. So that's why we're not seeing, you can see that even when it is 5 or like almost 5.5, you can still give potassium. But that's not, you can't do that in a normal person or in someone that does not have any hyperglycemic emergency. So yes, she's correct that in normal people, you need to calculate the deficit, then also calculate the maintenance, and then use that for your correction. But in hyperglycemic states, we tend to look at the absolute values and then give, because we're still going to give insulin. I don't know if that is clear.
It's clear,
Yes, sir.
sir. Thank you.
Thank you, sir, for the contribution. I think let me read out the chat. Dr. Obelum said, thank you for the presentation. In potassium management, you mentioned using 40 millimoles per liter for serum potassium of 3.5 and the same. So that has been corrected by
That has been addressed. Yes, thank you.
So many are applauding you for the good presentation. Somebody said, Dr. Coyote, Chief Coyote said, is this classification you give generally acceptable as acute less than 4 weeks, chronic of 8 weeks, subacute of 4 to 8 weeks? I think he wants you to clarify this. Is it a general thing or is just something new? I think that is the only thing in the chat box.
Sorry, Chief, I had a call. I didn't hear the last thing Chief Kayode's
So I want
question.
you to
Please.
dwell more on that classification of 4 weeks, 4 to 8, and more than 8. Is it a new thing? Depends on the disease, depends on the speciality, or is something that we consider general?
Sorry, Doctor.
Yes, Chief.
Dr. Yaya.
Okay.
Yes, sir.
You didn't finish reading.
Okay. Sorry, sir. Again, I'm sorry. You said CKD is greater than 6 months, CLD 3 months, chronic is 2 weeks, something like that. Acute stroke is about a week. How do you marry this? If CKD is 6 months, for us to say this is CKD, CLD of 3 months, there is another thing written, chronic,
chronic cough.
Chronic cough, 2 weeks. Then acute stroke about a week. So how do you marry this duration that varies with different diseases?
I feel there is a general classification of disease based on duration, and there are specific diseases that have unique classifications. Though online I was seeing chronic as more than 3 months in some places more than 2 weeks. I don't think there's any place that just gives the same for all conditions, in my own opinion.
So meaning it's not generalized, right? Depends on some diseases, right?
Yes, Chief.
Maybe sir will come and give more, shed more light on that. So any contribution again?
Good morning, everyone.
Good morning, ma'am.
Hold on. So I think the Chief Remigos has talked something on it, but I need to tell us that what she said, she was not totally wrong for that potassium replacement. In the new guideline, what we do is once it's less than 3.5, you don't even start insulin at all. You have to correct and you put that 40 millimoles in 1 liter until you're able to correct the potassium to be more than 3.5, then you start your insulin therapy. So once your potassium is 3.5 and above, the standard now is 40 millimole. That's where you divide it based on 3.5 to 2.5, less than 2.5 or above 5.5, it does not hold now. The only thing that is that if it is above 5.5, you don't give potassium, but you continuous monitoring the patient every hourly for serum potassium. And once you are getting it less than 5.5, then you now add your 40 millimoles. But once it's 3.5, the literature says stop your insulin or withhold, don't even give the insulin if it is from the beginning, then you do your correction. So that 40 millimole, 20 millimole, 10 millimole, of course, you will see it in older books, but in newer books now, you will not see it. Then, based on her definition of DKA, I don't know where you got it. You said hyperglycemia of 16 millimoles per liter. The hyperglycemia that the standard, even though for us endocrinology now, we are even using 11 millimoles and above. So, but the standard one maybe is 13.9, you will see. Once it's greater than or equal to 13.9 with your doses of 3 millimole and your bicarbonate of less than 15 or pH of less than 7.3, that's when it is DKA, not when the random is 16 millimoles per liter. I think maybe you need to correct that because I don't know where anywhere in the guideline, because even random of 16.7 is tagged as severe hyperglycemia. So it's because of the issue of euglycemic DKA that has come up, and that's why the random now has been dropped to 11 millimoles. So once it is greater or equal to 11 millimoles per liter and there's ketosis significant either in the urine or the blood, then with your acidosis, then that's DKA. Thank you.
Thank you, ma, for this wonderful contribution.
Thank you, Chief. Thank you, ma. I think it was
the
a
next
mistake.
presenter can start sharing the slide, please. Dr. Sani BA. Thank you, Dr. Ada.
Thank you, Chief.
Dr. EBA can start sharing his slide, please.
Any other presenter, Dr. Yaya, any other person that is ready should present. If Dr. BA is not in class. Dr. Yaya, please, by any chance, do you know who helped us to share Dr. Ada's slide?
Yes, it's Dr. Dalhatu that shared the slides.
As expected. Thank you so much, Dr. Dalhatu. I'm not surprised. You've really shown yourself to be such a wonderful personality. Well, I appreciate you, sir. Thank you so much. Dr. Ada, always very lucid. Fine, get no painful. Thank you so much.
Thank you, Chief. I'm loyal, Chief.
And now you find here now.
I don't know.
Hello, ma.
So thank you so much for the lucid presentation. Thank you so much, and all the participation from the participants. Thank you so much. I appreciate you. So anybody that is present, Dr. Yahaya, we still have time. So if nobody is present, the next topic, let's attempt it.
Okay. Can I attempt his question, ma? I have a slide on it.
Okay, you can.
Go ahead, please.
I think it's question 8. Go. Hello, doctor.
Have you finished with the other one?
What number is Dr. Ada?
Yes. Yes, sir, we are through with that.
Okay. I just wanted one small clarification. Oh, sorry for joining us back.
Okay,
I don't
sir.
know. I felt as if I heard the presenter talking about osmolality in DKA. I became confused. These are new guidelines. It's sounding confusing to me. Why are you interested in osmolality less than something in
Sorry, Chief, it's HHS. I'll edit the heading. That's why I deleted the presentation I sent to the group. That's the new criteria for resolution of HHS, sir.
Because you were mentioning DKA. Now I'm clearer now. All right,
I gave the guidance for both DKA and HHS, but typo. I don't know. There were a lot of mistakes on my presentation. Sorry about that, sir.
Okay.
Dr. Dalatu can go ahead, please. Dr. Dalatu, okay.
Okay, thank you for the opportunity. I try and attempt the question. The question says a middle-aged man with COPD, hypertension, and osteoarthritis who lives 4 hours from the hospital expresses his concern about clinic attendance. He's adherent with his medications. What is telemedicine? What are the options for telecare? What advice will you give him in case he has an emergency? The telemedicine is a practice of providing healthcare remotely through the use of telecommunications technology. It allows patients to consult with healthcare professionals, receive medical advice, and access certain healthcare services without the need for in-person visits. Telemedicine can include video consultation, remote monitoring, and digital communication for managing health concerns. The options that I could lay my hands on are: 1, telecommunication. The patient can schedule virtual appointment with healthcare providers to discuss his condition. In this case, like the chronic obstructive pulmonary airway disease, his hypertension, his osteoarthritis, as well as the medication and his general health concern. Whether that the medication he's experiencing a particular side effect, he can discuss with his healthcare provider where he could adjust the medication for him, change the medication, or even remove the medication accordingly, as well as monitoring the blood pressure where he can actually post how regular his blood pressure monitoring are, and then the consistency with the standard guideline like the dietary medication, his regularity with exercise, as well as for his osteoarthritis, looking at the exercise, the various exercise that he's considered to do, or his regularity with physiotherapy schedules. Then we could remote monitoring. This utilizes telemonitoring devices to track vital signs and symptoms related to condition, such as the blood pressure, oxygen saturation, and physical activity levels. The telepharmacy services access medication counseling, prescription refills, and delivery of medication to his location. Meaning, especially in the setting of HIV, where we are doing sometime with the key populations that schedule a pharmacy outside the hospital, where the physician or the healthcare provider discuss with those key population that you could go to a particular pharmacy. I will tell him what to give you and then refer them to that particular pharmacy where they don't have any issue of stigmatization. Then we have what we call teletherapy and counseling. Seek mental health support and counseling services for managing the emotional and psychological aspect of patients' conditions. The other question, what will you advise Sorry, I can't see something is covering. What will you advise the patient as when there is an emergency? So the advice for emergencies, given his distance from the hospital, which is about 4 hours drive, it is important to advise the patient about the emergency preparedness. First of all, we are going to have an emergency plan that will agree me as a physician and the patient. I encourage the patient to develop an emergency action plan in collaboration with the healthcare provider. This plan should outline specific steps to follow in case of medical emergencies related to COPD, hypertension, or osteoarthritis. We should have an emergency contact where the number of physicians ensure that the patient has list of emergency contacts, including the local emergency services around around his community. If there is any emergency services, like some states in Nigeria where they have emergency contact, like in Yobe State, where they have ambulance emergency services that are being displayed. So I will advise the patient to have the number of the phone number of those emergency services. Also, the contact of his primary physician, the person that is monitoring his hypertension, the physician that's monitoring his chronic obstructive airway disease and the osteoarthritis, and also any specialist involved in his care. Like in the case of people with osteoarthritis, the contact number of the physiotherapists that are used to monitor his physical activities. Then symptoms recognition. I will educate the patient about the warning signs for particular disease. Like in the case of chronic obstructive pulmonary airway disease, there are 3 questions that he should be conversant with: the level of shortness of breath. Once the level of shortness of breath deteriorated from the normal level of shortness of breath, is a red alert. And also the volume of the sputum production. Once the volume increases, then I'll explain to him that one also is not a good sign. Or the odor of the sputum, once it increases, also is a sign, is a symptom that he need to clarify. Or if there is blood stain, or when the level of activity. In the case of hypertension, some of the signs, like if he is having persistent or sudden onset of shortness of breath, persistent headache, or even inability to move any part of his body. Sorry. The shortness of breath, chest pain, or signs of heart attack. Also, community resources are identify local healthcare facilities where urgent care centers, like a primary healthcare or general hospital, or any other place where some level of care that we identify their professionalism, that the patient could quickly link to them in the setting of emergency before they finally get him to the tertiary or specialist hospital, or community support services that the patient can access in case of emergency. This includes knowing the location of the nearest health facility and the contact information for healthcare providers in that area. Then regular communication with the physician. Encourage patient to maintain regular communication with his healthcare providers, especially if he experiences any concerning symptoms, to ensure timely intervention and management of his chronic conditions. Thank you. This is my few attempts to the question.
Thank you very much, Dr. Dalhatu, for this wonderful attempt to answer this question number 8. Thank you very much. The floor is open for contribution by our colleagues and our teachers. Thank you. So any contribution, please? Hello?
We can hear you.
Yes,
Participants, especially those going for exam, speak up, air your views. Let's hear your thoughts. Fine tune what we need to fine tune. Dr. Dahatu is just anchoring this question. Any other person can contribute. That's why it's a discussion. So you add,
Hello,
you
thank you
add,
very
you
much.
know.
Can I say something?
Please go ahead, please.
Thank you very much for that wonderful presentation, Dr. Alatu. I think it was short and concise and direct. But my just concern is part of the plan that was outlined. I didn't see where family or caregiver support was mentioned. It's very important, I think, to give it a heading, because this kind of patient with chronic illness, and most of the times elderly patient, you should have a permanent or a very close by relatives. First, that should even join them in consultation. They should be following their medications. At the same time, noticing if they have any change in their medical illness. At the same time, they should be the first to even recognize if there's a sudden change in exacerbation of either the COPD or any change of obstetrics, because those kind of patients actually, they may not recognize, or they can even have acute delirium that may preclude them from noticing there's a sudden change in their health status. So I think there should be a heading for empowering, or probably the need for having a caregiver, a very close caregiver that has to be with the patient virtually on minute-to-minute basis. Thank you very much.
Thank you,
Thank
Dr.
you so much.
Muhammad, for this
And that was
addition.
a valid point. So you see, that's a discussion, because this question, they want to record this question, they can come from the angle of AI, they can come from other angles of telemedicine. So please, exam candidate, we want to hear your voice. Dr. Sani, thank you so much for your contribution. I think we don't have more contribution. Dr. Yahaya?
Yes, ma'am.
Chief Chitu is in class. It's better to be so calm. He used to be our chief in medicine. Yes, sir.
Okay.
Yes. Yes, I just contribution. I was waiting for the participants to air all the views before I come in. The speaker has done well. It's Dr. Dahatu, I guess. Yeah.
Yes, sir.
Yes. So I think the only thing I wanted to adjust is the types of telemedicine. Telemedicine can be classified into synchronous or asynchronous. Synchronous meaning that it's happening real time. Okay, and asynchronous means that it's recorded or kept somewhere prior to the doctor seeing it. So it may have been recorded hours or even days before the doctor sees it. Okay, then he takes action based on that. So with the asynchronous one, it's a recording. So there's only one type. So asynchronous is asynchronous. But synchronous can either be telemedicine proper or telemonitoring. Telemedicine is when you consult real time with someone via telecommunication. So you, what we basically do via things like Zoom and other forms of video-based communication, online communication that we tend to do. And then telemonitoring has to do with devices that are attached to patient that can give you real-time figures, real-time data, kind of like this continuous blood sugar monitoring, where there is a device in the patient that does all the monitoring, and then there's another device that can send it out to the doctor directly. Or same thing with ambulatory blood pressure monitors now. You can actually send out real-time audio and real-time values on data to the person that is receiving. So I think those are the things I wanted to add. I also want to tell the participants that a question on computers in medicine will definitely come up, especially topical issues on it. Or they could just go old school and then just ask you about medical informatics. So you need to be conversant with the use of computers in the management of patients and things like that. So you need to be up to date about such things, particularly now that we are in the era of AI and everybody say AI this, AI that. So you need to be, conversant with it. Then also we need to be conversant about use of computers in research. I think they've released questions like that in the past. Another common question they ask is they'll tell you, can you tell us 10 ways in which computers can be used in medicine? Okay, so whenever they make put a question like that together, then you're talking about many things, from education to research to actual patient care and all of that, to telemedicine, to robotics, to AI, to basically all of it. Okay, so I just wanted to add that. So we should be very conversant with it. There are many ways to bring questions, and they rarely repeat how they bring it out. They always change the dimension in one way or another. Hello, Dr. Christopher, over to you.
Yes, sir. Thank you, sir. We appreciate you, sir. Dr. Zahatu, thank you once again. I don't know if you mentioned what's it called? Inhaler technique. There's this other one I'm trying to remember. Partnering with a nearby hospital close to the patient in case of emergency, because since they need to distance to where you are, you want to partner with a hospital nearby. So in case of emergency, in that question they ask, when there's an emergency, what do you do? So an emergency, you'll be telling them to transport the patient to where you are. They are to take to the nearest hospital. So such partnership will have been existent. That's one of the